This session we will be discussing consumer information and health education. At the end of this session, you will be able to define health literacy and e-health, identify barriers to use of technology and issues associated with health-related consumer information. This is the knowledge age. Many people want to be in the know. People demand news and information, and they want immediate results and unlimited access. This is increasingly true with health information. More and more people in a trend known as consumer empowerment are interested in taking control of their health and are not satisfied being dependent on a healthcare provider to supply them with information. The Pew Internet and American Life Project survey report of 2013 indicates that 8 in 10 Americans who are online have searched for health information. The most frequent health topic searches are related to a specific disease or medical problem that the searcher or a member of the family is experiencing. Other frequent topics of health-related searches are weight, diet, and exercise, and health indicators such as blood parameters and sleep patterns. The 2011 survey reports that consumers also searched for information on food and drug safety. A 2006 Pew Internet survey tracked 8 million searches for health information by American adults in a single day and suggested that the most began their searches with a search engine. The impacts of these searches were reported as both positive and negative, and these impacts ranged from affecting decisions about their care, changing their approaches to overall health maintenance, and providing material for posing questions to healthcare providers, to feeling overwhelmed or confused by materials they found online about their health. It is important to note that these surveys are limited to those individuals who are online and do not reflect information of those who are not online. The digital divide is the term used to describe the gap between those who have and those who do not have access to online information. Nurses and healthcare providers need to be aware of the various components of the digital divide to ensure that patients and clients are receiving the health information they need in a format that they are interested in and can comprehend. Notably, persons with chronic diseases are less likely to have internet connectivity. So Fox and Purcell in 2010 explained the disparity in that having a chronic disease is associated with an increased age, level of education, ethnicity, and income, all factors that are associated with the digital divide. Persons living with a chronic disease who have internet access are likely to use the internet for blogging and online discussion forums, activities popularly referred to as peer-to-peer support. Misson and Cook in 2007 discussed the potential impact that technology-based health information dissemination can have on the know-do gap in developing countries. The know-do gap reflects the fact that solutions to global health problems exist but are not implemented in a timely fashion because of the lack of access to important health information. The internet connections in developing countries are widely scattered and may not be efficient or sufficient for viewing healthcare information. Misson and Cook described the use of a freestanding hard drive loaded with hundreds of CDs of health-related information in a web page format that responds to a search command. This is a great example of providing technologies that work with the constraints of the situation. Another example of addressing the digital divide is the growing number of health-related websites that support a Spanish language format. The goal of health literacy for all is one that is widely embraced in many sectors of the healthcare. It was a major goal of Healthy People 2010 and is being continued in the Health Communication and Health Information Technology objective of Healthy People 2020. Clinicians who have been practicing for some time recognize that informed patients have better outcomes and pay more attention to their overall health and changes in their health than those who are poorly informed. Some of the earliest formally developed patient education programs, which included postoperative teaching, diabetes education, cardiac rehabilitation, and diet education were implemented in response to research that suggested the positive impact of patient education on health outcomes and satisfaction with care. Glassman in 2008 updated the National Network Libraries of Medicine webpage on health literacy, and the web link is in the transcripts. She concluded that from the research on the economic impact of health literacy, that those persons with low literacy have less ability to manage chronic illness properly and tend to use more healthcare services than those who are more literate. In addition, she used results of health research to demonstrate the impact of low health literacy and the incidence of disease. The site states that health literacy is defined in the Institute of Medicine report Health Literacy, a Prescription to End Confusion, as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. For example, healthcare providers depend on a patient's ability to understand and follow directions associated with preparation for surgery or taking medications. It is also assumed, sometimes erroneously, that people will correctly interpret symptoms of a serious illness and act appropriately. The ability to locate and evaluate health information for credibility and quality, to analyze the various risks and benefits of treatments, and to calculate dosages and interpret test results are among the tasks that Glassman identifies as essential for health literacy. Other important and less easily learned health literacy skills are the ability to negotiate complex healthcare environments and understand the economics of payment for services. Parker, Ratzian, and Lurie in 2003 estimated that at least 1/3 of all Americans have health literacy problems and lament that in a time is money economic climate, healthcare practitioners are not always reimbursed for patient education activities, and this is still true today. The eHealth initiative was developed to address the growing need for managing health information and to promote technology as a means of improving health information exchange, health literacy, and healthcare delivery. The eHealth initiative website provides more information. Although the scope of the eHealth initiative goes beyond health literacy, a major goal continues to be empowering consumers to understand their health needs better and to take action appropriate to those needs. Poor interoperability among healthcare systems and failure to embrace national data standards for healthcare continue to be identified as barriers to the eHealth initiative. Further, concerns about privacy and security of information and the failure to invest appropriately in technology have slowed the development of this important initiative. Several states developed viable health information networks as part of the eHealth initiative. These include the Utah Health Information Network and the Vermont Health Information Technology Plan. These are examples of attempts to implement eHealth initiatives. The Centers for Disease Control and Prevention maintains an interactive map of the United States that provides access to health literacy and eHealth initiatives by state. Healthcare organizations use a wide variety of approaches and tools to promote patient education and health literacy. Although the old standby for disseminating information is the paper-based flyer, some healthcare organizations are recognizing that today's consumers are more attracted to a dynamic rather than static medium. In addition, the cost of designing and printing pamphlets and flyers becomes prohibitive when one considers the rapidity of change of information. The brochure may be outdated almost as soon as it is printed. One approach to deal with these issues is to have patient education information stored electronically so that changes can be made as needed or information can be better tailored to a specific patient situation, then printed out and reviewed with the patient. Another old standby approach that is still widely used is the group education class. These classes initially were developed to help people manage chronic health problems, for example, diabetes, and were typically scheduled while people were hospitalized. Now, many healthcare organizations also sponsor health promotion education classes as a way of marketing their facilities and displaying some of their expert practitioners. The movement from static to dynamic presentations began in many healthcare organizations as DVDs and videotapes that were shown in groups or broadcast on demand over dedicated channels via television in patients' rooms. Healthcare organizations are now also taking advantage of the fact that patients and families are captive audiences in waiting rooms by promoting education via pamphlet distribution, health promotion programs broadcast on television, and health information kiosks in those locations. The kiosks are typically computer stations and often contain a variety of self-assessment tools, especially those related to risks for diabetes, heart disease, or cancer. And they contain searchable pages of information about specific health conditions. The self-assessment tool represents yet another step forward in technological support for education. In addition to being dynamic, the kiosk is interactive. On the assessment page, the user is asked to respond to a series of questions, and then the health risk is calculated by the computer program. One caution, however, is that just because the information is made available, it does not mean that people will participate or that they will understand what they have experienced. Issues related to the level of health literacy, the digital divide, and the gray gap still exist in these situations. Some healthcare organizations are using social media as health education tools to promote actual engagement of audiences rather than as means of a one-way messaging. The literature suggests that the use of social media in health promotion must lead to engagement between the health promotion organization and its audience members. That engagement must provide a mutual benefit, and that an engagement hierarchy culminates in program involvement with audience members in the form of partnership or participation as recipients of the program services. The Centers for Disease Control has an excellent social media toolkit that can be used by health educators to guide the planning and implementation of social media strategies for health promotion. And this toolkit can be accessed at this following website. Promoting health literacy in school-aged children presents challenges to health educators. There is wide agreement that childhood obesity is a serious and growing issue, which is related not only to poor choice of foods, but also to the sedentary lifestyles promoted by video games and television. In addition, the time once devoted to health and physical education programs in schools has given way to more time spent on core subjects such as math and science. The Children's Nutrition Research Center responded early to these challenges by supporting the development of nutrition education programs as interactive computer games, video games, and cartoons referred to as edutainment. These e-health programs are developed specifically to appeal to the generational, so the highly connected and computer literate, and cultural needs of this group. Flores described the Family Web Project, which uses comic strips to impart nutrition information, and Squire's Quest, where the students earn points by choosing fruits and vegetables to fight the snakes and moles that are trying to destroy the healthy foods in the kingdom of Selah. These are great examples of health education programs that are designed to appeal to this connected generation of learners and their intuitive ability to use interactive technologies. Donovan in 2005 described an interdisciplinary web quest designed to appeal to older school-aged children. The quest is interdisciplinary in that it requires reading comprehension, critical thinking, presentation, and writing. Thus, core skills and health literacy skills are learned in a single assignment. Students are directed to the web to search for information on the pros and cons of low-carbohydrate diets and obesity prevention. Students learn along the way as they search for information, collect and interpret it, and then develop a presentation and a final paper. The cancer game was developed by a young man taking a college class on Macromedia software and who had previously undergone a bone marrow transplant. Subsequently, he and a professor collaborated and expanded the project to its present form. The game is designed as an arcade-style video game for cancer patients to relieve stress by visualizing the fighting of cancer cells. Although cancer victims of any age can access and play the game, it has a special appeal to children and adolescents. Similarly, Ben's Game is a video game designed to help relieve the stress of cancer treatment for children. Games have also been designed for other conditions such as diabetes, and you can access these newer games on the internet by typing health games into a search engine. It is important to be sure to review the information presented in the game for accuracy before you recommend it to parents and children. Nurses and other healthcare providers need to embrace the internet as a source of health information for patient education and health literacy. Patients are increasingly turning there for instant information about their health maladies. Health-related blogs, short for weblog, an online journal, and electronic patient support groups are also proliferating at an astounding rate. Clinicians need to be prepared to arm patients with the skills required to identify credible websites. They also need to participate in the development of well-designed, easy-to-use health education tools. Finally, they need to convince payers of the necessity of health education and the powerful impact education has on promoting and maintaining health. The Health on the Net, or HON Foundation, in 2005 survey described the certifications and accreditation symbols that identify trusted websites or trusted health sites. The OnCode and Trustee were identified as the two most common symbols that power users look for. The survey also indicated that internet users look at the domain name and frequently gravitate toward university sites, .edu, government sites, .gov, and healthcare organization sites, .org. Half of the survey respondents were in favor of the use of a domain name called .health to identify quality health information websites. In contrast, the Pew Internet Report of 2006 indicates that nearly 75% of online searches do not check the date or the source of information they are accessing on the web, and 3% of online health seekers report knowing someone who is harmed by following health information found on the web. The U.S. National Library of Medicine and the National Institutes of Health jointly sponsor Medline Plus, a website that has a tutorial for learning how to evaluate health information and an electronic guide to web surfing that is available in both English and Spanish. A similar guide explains that the major things one should evaluate when accessing health-related resources on the web. Suggest that parents visit these sites to become more adept at identifying whether a website is credible before they adopt the recommendations provided. Clearly, the clinician is very important in patient education. Some providers have developed a list of credible websites and apps that are shared with patients or family members. Recommendations for websites might include the U.S. Department of Health and Human Services sponsored Health Finder site, and this is a website that is dedicated to helping consumers find credible information on the internet. Other excellent sources of reliable information are the National Institute of Health. Predicting future directions for technology-based health education is somewhat difficult because one may not be able to completely envision the technology of the future. One can, however, predict that some current technologies will be used increasingly to support health literacy. For example, audio and video podcasts may become more commonplace in health education and be provided as free downloads from the websites of healthcare organizations. The literature described the processes used to create patient and family surgical video podcasts. This began by digitally recording actual pediatric otologic surgeries, or ear surgeries, and then edited the videos, developed a script, and finally recorded the audio. They report that the educational podcasts were developed in 8 to 10 hours, excluding the surgical recording time. These podcasts were used to supplement the traditional face-to-face patient and family education sessions for pediatric otologic or ear surgeries. Voice recognition software used to navigate the web may reduce the frustration and confusion associated with attempting to spell complex medical terms. However, the confusion and frustration may increase if the patient or client is unable to pronounce the terms. Voice interactivity should help to reduce the digital access disparity associated with those who have limited keyboard or mouse skills. For those persons with visual impairments, some websites may provide both audio and text information and support increased text size for greater ease of reading. Many websites associated with the government and national organizations are also providing multiple language access to health information and decision support tools. The multi-language access broadens the population to whom education can be provided, and the decision support programs allow users to access results that are tailored to their age, risk factors, and disease state. Those individuals who are frequent email users may be interested in being able to communicate with physicians and other healthcare personnel via email rather than the telephone. This idea may meet with some resistance from physicians who perceive the email correspondence as bothersome and time-consuming. However, work efficiency might also increase if patients and their needs are screened via email before an office visit. For example, because of an email correspondence in lieu of an initial office visit, medications could be changed or diagnostic tests could be performed before the office visit. In addition, patients could be directed to an interactive screening form housed on the website where they would answer a series of questions that would help them make a decision about whether they should call for an appointment, head for the emergency room, or self-manage the issue. If self-management is the outcome of the screening tool, then the patient or caregiver could be directed to a credible website for more information. The idea is not to interfere with or replace the face-to-face visit, but rather to supplement the physician-patient relationship and perhaps streamline the efficiency of healthcare delivery. McRae in 2005 also suggests that physicians may be resistant to providing email consultations and recommending health-related websites because of the potential for malpractice liability. There is some evidence, however, that text messages, reminders delivered via a cell phone are more effective and efficient as appointment reminders than traditional phone calls. Similarly, in one descriptive research study, it was found that parents of children who recently visited an emergency department were interested in receiving follow-up communication from healthcare providers by text messaging and/or email. A major barrier to widespread adoption of email and text messaging among American healthcare providers is the fact that reimbursement mechanisms for electronic healthcare are inadequate or non-existent. Piet in 2007 describes the use of interactive behavior change technology to improve the effectiveness of diabetes management. The goal of the interactive behavior change technology is to improve communication between patients and healthcare providers and to provide educational interventions that promote better disease management between visits. The combination of electronic medication reminders, meters that track glycemic control longitudinally, and personal digital assistant-based calculators was found to support the behavioral interventions necessary to better manage the diabetes. As a conclusion to their study, Watson, Bell, Kevdar, and Grant in 2008 cautioned that even though patients are part of the digital divide, or lacking access or skill in electronic communications and internet use, one cannot assume that they will be resistant to using other forms of technology to support health. These authors compared internet users to non-internet users and found that both groups were willing to learn new technology to manage type 2 diabetes, including wireless communication devices for information sharing with physicians. Healthcare practitioners may soon embrace the use of information prescriptions that direct patients and families to credible websites, including government and healthcare organization websites and wikis and blogs that may help them understand their health issues or share information and seek support from others who have similar issues. Information prescriptions are prescriptions of focused, evidence-based information given to a patient at the right time to manage a health problem. The National Health Service in the United Kingdom has developed an information prescription generator that can be used by providers or public to access web-based health information. It is clear that the consumer empowerment movement will continue to drive the need for access to quality health education and support programs. In an ideal world, practitioners will design educational materials that are user-friendly, culturally competent, interesting, dynamic, and interactive, and that meet the skills, education needs, and interests of the user.